Yeah,
And
that's
I can see my screen behind you that it worked.
yep.
So
That looks perfect. All right, we are on. Okay. Turn it around. All right, class. So we're going to get started now. Dr. Smith Ryan is a very good friend of mine and an excellent person. I'm every time I see her work and get to interact with her, I just get inspired to sort of do better work. And so I hope you guys feel the same way after hearing from her today. Um, Abbie, we've seen a little bit on this so far the last week from Katie Hirsch, who you know, and Stacy Sims, who you know. And so those are both pre-recorded, so we couldn't ask questions during those times. And so what's really going to be great for us is to go through what you have here and then sort of go into that Q&A session for the remainder of the time today. So the class has been instructed to ask some questions for you after you go through your plan slides. And just for the class's perspective, Dr. Smith-Ryan has been sort of on the forefront of this for the entire time. And I think her perspective on it is really important to hear because remember I was talking about the camps people get in, sort of a little bit of evidence and run with it. Or a little bit of evidence, not enough to do anything. And I think she's a hybrid of those because of her experience as an athlete. And hopefully we'll hear a little bit about that today and how she got involved. But thank you, Abbie. I owe you for this. And I'm going to turn it back so you can see the class and let you go. Thank you.
thanks. Thanks for the invitation. And I'll just say, I have a couple slides here, and I notice our title of the chat was female athlete, and then another one was related to peri and postmenopause, and we can talk about whatever you all want. I just wanted to also add, like, I value the translation of research to practice. And that's where I'm at in my career. So with Katie, for instance, she trained with me and is early on in her career in developing some really cool research. And I am still doing some really cool research. One thing I'll mention with Mike, but now I actually get to use a lot of the research to, for instance, create research protocols to ensure that we are adequately evaluating females across the lifespan to have important outcomes. Or I use a lot of the work to help nutrition companies formulate products specifically with physiological considerations for women in mind and shed a lot of light to that. So happy to even talk about some of those kind of hybrid applications here. I did want to share a little about myself. I think the reality of this space is when I started. So I was a former collegiate athlete, a distance runner, and I was plagued with many stress fractures, and it was likely due to underfueling unintentionally. And also during that time, like I actually fell in love with research as a freshman in undergrad. I still thought I wanted to go to med school, but really identified this ability to ask a question and answer it, and have been doing it ever since. I looked back at a long time ago for a presentation. My very first publication was actually looking at creatine in women. And my focus on women really has narrowed in over the last 8 years, but I always included males and females. And it was really the data that led me to say, hey, we actually need to spend more time looking at female only data. I am a mom, and I think that's important as, like, yes, we have studied women, but also I always love this field and like we are our own experiment. And so going from an athlete to I think the most athletic event you'll ever do is giving birth, and even the nutritional approaches around pregnancy. And then now I'm in my early 40s. I haven't hit perimenopause yet, but just the understanding of the physiology around female phys is so fascinating. And what you hear and what's actually happening, if you put science into that, it has a huge impact, especially in our field of exercise and nutrition. And then I have a huge interest in supporting the younger generation. These are a couple of my lab groups, and I say this because as grad students, I remember going to my first NSCA conference. I was a junior in college, and I looked around, and it was literally all men wearing gym clothes. And I thought to myself, like, where do I fit? And there were some really incredible women that I have latched onto as mentors, but none of them had a family. None of them were like research active. and none of them were still contributing to the field. And I thought to myself, like, we need more of those. And so I've thought for a long time, do I do something else? But most of what I do is really the idea of creating opportunities for the next generation, and hopefully sharing things that I would have done better, as well as exposing some of the challenges, because this road is not easy, but what are the things, and good collaborators like Mike are a big part of that. So I wanted to plant that of, sometimes we just talk about the science, but in my life, especially as a mom and a lab director, like running your own lab is definitely like a small business. I feel like we don't talk a lot about those aspects. So grad school is a really good time to think about those. So happy to answer any questions on that realm. Now I have a couple slides, and I'll stop here in a moment and ask some questions. I want to give you just two thoughts here. With every study, and even whether it's a study design or when we evaluate science, there's some key physiological differences we should start to understand. And honestly, this is the basis for a lot of the conversations we have of, can the data that we have in men apply to women? Should we be making different nutritional recommendations? And it all comes back to, what are the systems that are different? For instance, let's look at vasodilation. So a lot of my work early on looked at things like citrulline malate and nitric oxide stimulators, whether that be beetroot or pomegranate extract. And like the vasodilation is one key difference. So we actually should probably be formulating things slightly different. And I would imagine, like for me, like if you have a young female, they actually have some greater vasodilation post-exercise, and then you can see some other aspects here, smaller vessels. But we might want to look at different dosing or different products for a female in relationship to vasodilation than we would for a male. So just a couple thoughts here when we look at these outcomes are we accounting for hormones? Are we understanding that physiological difference? And then a lot of times the data that we do have in men can be applied, but not always. And then I think this paper is literally now quoted everywhere you go, which is great. But I think it's hindered us in some ways. So the quote is, only 6% of sports science data includes women, which is pretty staggering when you think about it, or it includes only female participants. And then there's even less when you look at women in midlife. And so you can see like a sample size of 39 included women in midlife, which is pretty crazy when you think about our population demographics, that women tend to outlive men. And when you look at a lot of the physiological things that we are trying to tackle, both with nutrition and exercise, they are going to be most impactful for middle-aged women. And so I look at this as, let's not necessarily wait for more data, but let's see what the data says now, so we can actually start making an impact on this space. Okay, so I'll leave this slide up here and then open up for some questions. So just in case, and I'm sure you probably had the definitions of the different life phases. Premenopause actually starts at the time of a period. So the average age in the US is 12. There's a number of considerations here that I think nutrition and exercise can support, not only muscle and bone development, but a lot of things within the menstrual cycle. So more than 70% of women complain of dysmenorrhea or painful menstrual cycles, and hardly any are using nutrition to help support that. So a big area of interest here, and understanding, like, if you are having painful periods, it probably will impact exercise performance. And then this perimenopause is really 45 to 52, with symptoms starting even earlier than 45. And this is where I think we have a big area of opportunity and really kind of an ethical need to help this phase. And so I would ask, think about, especially the men in the room, most of us have moms or siblings or significant others, and there's just so much that happens here. And as we see these dramatic changes in health, so cardiovascular disease significantly increases, lots of changes in bone, things like sleep, and then this anxiety and depression. I'll just make one last thought. Right now, we see the biggest rise in eating disorders actually in middle-aged women because of body dissatisfaction and some of these mental health changes. We also see the number, like increased prescribed anti-anxiety and depression meds, when in reality, things like complementary medicine and exercise and nutrition could really help this category, but lots of unknowns there. So with that, I have a couple other slides, but I'm going to stop sharing and see what kind of questions maybe from your last couple lectures and anything that I brought up, if you guys want to jump in.
Awesome. Thank you, Abby, for that. Anyone in the class want to get started, or do you want me to start talking? All right, we got one.
Thank you so much for coming to speak with us today. I just had a question as far as like with athletes who are dealing with amenorrhea or oligomenorrhea, like what are some of the considerations that you think are beneficial for like a support staff to kind of help combat some of those issues?
Yeah, it's a big question. And I was thinking maybe Katie covered some of that. One, I would say it's probably the number one, and before they lose their menstrual cycle, most athletic females are under consuming calories. And so that's honestly a lot of my work involves body composition. And so many people are scared of that conversation. When in reality, if you use body composition, specifically muscle, it's a very good conversation starter because it's so impacted by underfueling. Usually we will see changes in muscle over a season or before periods start, before periods stop. And so having a conversation with an athlete of, hey, you're losing muscle, which is directly impacted to performance. It's not about percent fat. It's about maintaining muscle. What athlete would not want to do that? The other conversation that's also easy to start with is just this nutrient timing conversation. And we've done a lot of work there of a lot of times it's just helping the athlete prioritize the nutrition, the nutrients around exercise can really help with some of those hormonal changes. And then even there's some new work that shows if females are going for several hours without eating, so 3 to 4 hours, that increases their risk of amenorrhea. And so even that conversation of, okay, let's make sure we're prioritizing food around our training, but also making sure we're having small meals throughout the day. Because the other big thing is GI distress is very much more prevalent in female athletes. So some of those strategies, that kind of nutrient timing and small meals can help give them some power back.
Yeah, that's great. Thanks for that. Like we have conversations here at FSU where like almost all of them are like the sports staff are saying we can't even look at body comp and it can't be shared with X, Y, and Z. The athlete can't know about it. The coach can't know about it. Just the medical staff, really. Have you faced that with your work with athletes now? And is what you just said how you overcome that, or what have you been doing to sort of fix that?
Yeah, it is still a very contentious topic when I think it's actually, I mean, to be frank, quite appalling. So as a former female athlete, we had to undergo like skin fold testing almost every month, which one is way too frequently. And then if you don't actually tell me my data, you know that athletes talk amongst themselves. And so it actually creates a lot more psychological stress by withholding information, particularly when we think about our female athletes, and there's a lot of data to support this. Female athletes are highly educated. And if you think about if they're in college, they're going to find out anyways what those data mean. And so, and then we'll take it one step further, is the best time for female athletes to work through some of their challenges with eating disorders and underfueling is in a college population because there are so many resources. And so a lot of our conversations focus around, okay, one, maybe involve some like sports science, physiology staff, because a lot of times dietitians and support staff are not actually trained in what the body comp means and how to modify it and how quickly to measure it. Even some of our work has looked at how does the menstrual cycle impact the accuracy of that. And then really looking at things like a lot of our work has looked at fat-free mass index as a benchmark and injury prevention and tracking. And for instance, it's a really good yellow flag and red flag that's been a precursor before some traumatic injuries of like, hey, if we're low on muscle based on standards within your team, that's a really important thing to share with our strength staff. And then with our strength staff and coaches, the coaches don't really need to know the body comp. That part is not there. It's not going to change their coaching approaches. But the strength staff do, particularly with a focus on, is their programming impacting muscle? Is it over time impacting bone? And then we've also focused on limb asymmetries of, for instance, how does the muscle look in the glute, the quad, and the calf? And then how would that impact their unilateral training or injury prevention and some of those things? So really almost like separating some of the key messages and then trying to also filter in injury data and availability data, for instance, with things like athletic training and sports medicine. How does the body comp actually inform some of their practices?
Yeah, that's great. Great help there. Question?
From a research perspective, if you're designing a study in which you can't control for the menstrual cycle, what do you think is the best, most thorough way to report the menstrual cycle?
Yeah, great question. Because not everyone needs to do research across the menstrual cycle, but what our fields need to do a better job of is characterizing the sample, of really getting granular of, are these women having periods? Are they on hormonal contraception? Even some tracking is really helpful. So depending on the study, the more data you can get about their reproductive history is going to be really helpful and can impact outcomes. We developed a questionnaire, and I think maybe I shared that with Mike. Like, we have a questionnaire that people can use that goes through some of those key things. And then at a minimum, what we suggest is really just trying to capture, like, are they menstruating? How long? Are they taking hormonal contraception and what type? And then depending on the study, can you at least capture what phase of the cycle they're in when they're with you? Or maybe you're dealing with female athletes and many of them do not have a menstrual cycle. That's really valuable information as well. So more just talking about it and reporting it in the methods section.
Thank you.
Mm-hmm.
So Abby, I have a follow-up for that. With the oral contraceptives, there's a lot of controversy now we hear on social media predominantly of how they may or may not impact performance. And we've talked about it in this class a little bit, but I don't know anything new on that. Are there types that athletes should be taking? Are there types that athletes should not be taking? Does it impact strength at all, or power and VO2 max, or any of these other variables that athletes would care about?
It's a great question. And I think, as a female, we probably picked the worst day to talk about this on election day, but when we think about hormonal contraception, one of my grad students said the worst injury a female athlete can have is being pregnant. And I was like, oh, that's kind of harsh, but it's not wrong. If a woman is trying to compete, pregnancy prohibits that, and so I think we first and foremost have to say, like, there's a reason to take hormonal contraception beyond some of the reasons, like for pregnancy purposes.
Right.
When you look at the other reason that most women are taking hormonal contraception, it's usually because of some sort of side effect, some negative symptoms related to the menstrual cycle. And so indirectly, hormonal contraceptions could actually improve performance because a female athlete feels better. Then when you look at some of the science, and we've tried to dial into this, the best way to describe it is a female athlete is going to overcome a lot of these physiological effects. Like, they can still produce high amounts of power and performance. Maybe over time, like, because hormonal contraception, we're talking more about our oral contraception, it's basically you have this low grade hormones all the time. You don't have that cyclical flow. And so there's some thought that maybe over time you won't see as big of changes. It might blunt that peak end of things like muscle growth and peak performance, but it's more consistent. So I would say like right now it's a wash, like meaning that you can overcome any of those negative consequences with appropriate training, so periodization, stimuli, and nutritional support. And it's hard to overcome some of the, like it oftentimes helps these women feel better.
So that kind of dovetails right nicely into some of the things we've been reading and here around perhaps like more carbohydrate needs at certain parts of the cycle or more reliance on fat. And you see some extremists go like, oh, well, during this phase, like don't eat carbs and just eat your fats and vice versa. Or in this phase, for an athlete, you can't really train like that. But I'm just interested in the nutrition part. Do women or should women change their macros around the phase of their cycle?
Yeah, I mean, it's if we're talking about like elite women that are competing versus women that are trying to optimize body composition, those are two different goals. But if we are talking about women that are performing and competing, we know that most of them are under consuming carbohydrates to begin with. And usually carbohydrates are the key thing that will impact performance. And so generally, yes, in the follicular phase, we tend to oxidize more carbohydrate. So, I mean, nutrition can get complicated, but one, I would start with, are they getting adequate amounts of carbohydrate? And if they're not, adding carbohydrate will absolutely help. And that's usually the first conversation. If they are also doing some, exercises that will impact muscle glycogen, then a slightly higher intake in carbohydrate in that phase will be helpful. On the flip side, that luteal phase is where you tend to shift more towards fat oxidation. That doesn't mean we would necessarily reduce our carbohydrate. And in reality, in that phase, we also see usually like a couple 100-calorie increase in energy expenditure. So oftentimes it's more of a conversation of, okay, we actually are going to add a small snack with not just carbohydrate, but also some amino acids. I don't know if that answers your question.
Does I just sometimes we're asked like should we be making any changes in the diet over this period of time? And I think for the elite athlete that makes sense to perhaps up carbohydrates in one segment or another, particularly if they're under fueled. What about for the other people, the people who are not elite, just general pop, they like to exercise but body comp is of major concern to them?
Yeah, so then I would say, I mean, first, I feel like a lot of these conversations, a lot of things that come up with a lot of students I interact with and social media is like you'll see seed cycling and varying your training across the menstrual cycle. None of that is valid. I would say within a nutritional component, what we do see is there may need to be some nutritional changes to support better recovery. So in the luteal phase is where a lot of women don't feel great, and there's some thermoregulation changes as well as some greater edema, maybe some inflammation like right before, and even symptoms of a period right before they actually menstruate. I would never say don't do heavy training or high intensity work, but I would say optimize your nutrient timing. And a lot of our work has actually um, most of our nutrient timing, and most people know you should have something to consume post exercise. So for instance, most people are aware of, oh, like have chocolate milk post exercise. But what I might do is, and what the research has shown is actually women should prioritize what they eat before exercise. So particularly in this phase, I might, recommend more of like a carb protein mix pre-exercise and then a whole meal after to maximize recovery, not necessarily just due to changes in oxidation of fat per se.
So I know you did a study in that space where you were giving protein before exercise or not, and looking at daily energy expenditures throughout the whole day. To put you on the spot here, but can you remember any details from that study you could share with us?
Yeah, it's one of my favorite studies because a lot of my work involves high intensity interval training, not because it's better or should replace this. I feel like zone 2 training is such a contentious topic right now, but high intensity training has dramatic physiological effects. So we compared, okay, let's do 3 types of training: aerobic exercise, high intensity interval training, and high intensity resistance training. And let's look at carbohydrate beforehand or protein beforehand. And surprisingly, protein beforehand significantly increased energy expenditure after all of those exercises, with a better impact on high intensity interval training and resistance training. And protein beforehand also maximized fat oxidation post-exercise. So when we think about some of that, now fat oxidation doesn't always mean fat loss, but fat oxidation does often mean minimizing glycogen depletion over time. And since then, we've done a training study, which has carried into some more work of like protein prior to exercise for women seems to be a really advantageous approach to maximizing training volume, maximizing muscle protein synthesis and increases in muscle, and maximizing body composition.
Do you think that would be different in men?
I think pragmatically, maybe, because men do relatively a better job of fueling prior to exercise. So I
Mm.
think some of it is just a matter of like, are women becoming underfueled? The other thing is based on some of the potential amino acid oxidation differences that even we're trying to tease that out now. It may be slightly different.
Thank you. Hannah, do you have a question?
I was just gonna ask if you think low energy availability or the symptoms of low energy availability would be different in different phases of the menstrual cycle.
Good question. Maybe. To me, the number one symptom of low energy availability is GI distress. And when you look at GI distress, it is worse in the premenstrual phase, so in that luteal phase. So it honestly, it could be a really good yellow flag. Like someone may experience worse symptoms in that premenstrual phase if they're have low energy availability. The double-edged sword is because of that slightly increased energy expenditure in that premenstrual phase, it may put someone into low energy availability. So I do think they probably go hand in hand.
So do you think that would have like a greater effect on athletes who already have a higher energy expenditure than just your normal person?
I don't know if we can say athletes have a higher energy expenditure, honestly, because they have so much mitochondria. Sometimes they're so efficient, their energy expenditure is lower. But I would say, I think athletes tend to feel those symptoms. They're more in tune with some of those effects versus someone that's less active. And then they're expending so much. So yes, I think they will be more impacted, not necessarily because of energy expenditure, but just because of what they're trying to accomplish.
Thank you.
Yeah, thanks for your questions.
So due to taking oral contraceptives, women will experience reduced levels of hormones throughout their cycle. And so would it be wrong to think that women taking those oral contraceptives would experience more consistent physical performances compared to those who do not take the oral contraceptives and have those varying levels of hormones?
It's a good question. So first, a lot of times females that are taking hormonal contraception are actually getting more hormones than they can produce, especially if they have some kind of amenorrhea or dysfunction to that hypothalamic response. So that's a little bit of a different, like estrogen is a superpower. Like it actually is very helpful for some of these adaptations. So one way I would look at it is hormonal contraception can often raise that level. The second half of what you said is true of like the consistency matters. And so some of what the literature says, and I would say this is so dependent on the person and so can be overcome with programming, but really you might see more consistent adaptations in those individuals that are taking hormonal contraception, but maybe have some of their maximal because they don't have like that peak phase and the luteal phase, they may see some of those maximal responses kind of not met or downregulated. Right now it seems to wash out a little bit, and there's also so many different types of hormonal contraception. So from like a practical scenario, honestly, I think we need to have more questions about optimal program design. And if we can implement that, there's no reason to believe the female muscle will respond different at this time.
Perfect. I had another question just with your experience having been an athlete. Within that space, where do you think the biggest gaps are as far as people who are working with those athletes, like misconceptions that you've personally seen that you think should be, again, kind of just corrected to better help the athletes be healthier while they're at the university, but then again, like kind of preventing issues that could develop after they leave?
That's such a great question. I mean, I think first and foremost is talking about periods and having everyone to be equipped with that, because even to this day, like especially at UNC, there's a lot of this, oh, like that's not in our scope of practice, or we don't know about that. Because really, when you think about it, in any given field of training, even things like exphys and nutrition, women are still considered a special population, and you might find one small paragraph. And so then this is this taboo conversation, and it creates this environment of like there's no one that can talk about it. And so really it's honestly some more education and this conversation around periods. Like when I was an athlete, it was a badge of honor not to have a period. How great. But no one talked about the implications on bone and ability, like reproductive health and the ability to have children. And now it's definitely a much bigger conversation, but it is mind blowing. One, what women are not told about their bodies, about periods, and then even how you deal with that. Like I think about, I had to run around in basically bikini bottoms on a track, and you think about like volleyball and softball and white pants. Like no one actually has the conversation that a menstrual cycle is very normal. And here are some of the side effects that you might experience. Some women, I mean, I don't know the handful of ladies in the class, if any of you have, like, I know students that have a debilitating menstrual cycle pain. Like, how do you do that and compete when in reality you could have a conversation of, oh, here are some anti-inflammatory approaches to take. So it's that conversation, especially among men. Most of the coaches are men. And I think recognizing that men might not know, but women don't know either. No one teaches us this stuff. You just figure it out as you go, particularly as you get older, like as you transition from a normal menstrual cycle into perimenopause. It's still such an under communicated space.
Hello, I work not so much in athletic performance as much as like cardiovascular health across life. I kind of want to maybe bring the conversation more to general health, focus on peri and postmenopausal women and your hormone replacement therapy. And I know there's a lot of studies on proper timing, duration, and stuff like that. And what is your outlook on that?
Yeah, I mean, this is where I spend a lot of my time. It's a very big question, and I think this is still somewhat of and maybe you guys are aware, and I do have some information I can share, but for a long time, hormone replacement therapy, the data was misread and basically says it causes cancer, when in reality, like if you're at risk for cancer, for breast cancer, you might want to have those conversations. And now we see that, okay, that data wasn't that detrimental, but still, so now we see a lot of people saying like, hormone replacement therapy fixes it all. When in reality, even if you adjust your hormones, you still need those lifestyle changes to really support health, things like exercise and nutrition. And that's where it gets fuzzy of like, how do they go hand in hand, particularly when you look at those changes in cardiometabolic health. So you brought up cardiovascular disease. I would also throw in diabetes. Even if a middle-aged woman is extremely healthy and they exercise and they eat right and then they go on hormone replacement therapy, you will still see dramatic changes in things like blood pressure, glucose, triglycerides. And so, but nobody's having that conversation. And so I think we need to have some first lines of defense of what do we need to change, particularly for those who are healthy. But then what if you go into that phase with some current diseases? You'll see an even greater risk of disease. So I don't know if you have like a specific question, but a lot of what we're trying to look at is the other piece of it that is hard for me to take away is that time frame. So 40 to 55 is women are also at the top of their careers. They're trying to take care of everyone else, yet they feel terrible. There's a lot of data on the amount of impacted work time, and you see this change in health. So what do we do? How do we support them? And that's to me where a lot of like, okay, how can we have time efficient, effective approaches to exercise and nutrition that aren't like, okay, throw out everything you're doing and let's do it this way, is how do we feasibly integrate that into their day to day? I don't know if you have like a specific question that I can answer.
I guess one thing to follow up on like the specifics. So I've just seen some talks on maybe starting before you start with perimenopause versus people who wait until postmenopause. And if you have a stance on general guidelines, is it starting to appear one way might lead to more favorable health outcomes?
Yeah, I mean, great question. I mean, if you are a chronic exerciser and pre-menopause, you will have much better outcomes. We've seen, and you know, we actually have good data in postmenopause, but what we're seeing, and it's not just our lab, that perimenopause is the key time to make changes. Now, if you are dealing with a postmenopausal woman and she hasn't made changes, it's never too late. But it does seem that things like greater lean mass and greater vigorous exercise in perimenopause reduces some of those symptoms and those cardiometabolic consequences. And then also think to yourself, one of the key reasons we see a lot of these changes is because sleep is so impacted. Women are having hot flashes, they're not sleeping. I don't have any trouble sleeping. It's because my day is full and I exercise. So when you think about some of the intangibles, so I would say consistency trumps everything. If you can get someone to do some of these lifestyle changes in pre-menopause, absolutely. But peri will have a huge impact if you can make the changes there.
Okay, hopping over. So jumping back to the conversation on hormonal contraceptives and stuff, I was curious if you've seen any correlation or heard anything about the correlation between amenorrhea versus the absence of a period on birth control and the symptoms of that. So like someone with amenorrhea versus someone who is on birth control and doesn't have a period, does that have the same physiological effects? Because I know sometimes when people are on hormonal contraceptives, that period can go away.
So are you saying, so amenorrhea means no period. So
Right.
you're saying like someone that's amenorrheic, not on hormonal contraception?
Right.
I
So
got it. Yeah, I mean, I think the hormonal contraception often masks the ability to quickly detect amenorrhea.
mhm.
And then the consequences, though, will be the same.
Okay.
Meaning, like, you're still going to have a number of physiological downstream effects of not having a period. I do think what we know now is because the hormonal contraception is providing some hormones, you might not see, for instance, it might take a little bit longer to see those consequences because you are getting that artificial estrogen and or progesterone. It probably depends on what type you're taking.
Okay. So like someone who's just a normal person,
Mhm.
who's on contraceptives,
Mhm.
and that those contraceptives remove that period for whatever reason.
Oh, that's different.
Different. Okay.
Yeah, so like some forms of contraception, like a low dose estrogen or an IUD, often a woman may not actually bleed.
Right. Yes.
That's different. That's just hormonal withdrawal. That's not necessarily impact. That's different than amenorrhea. I get your question now. Yeah, totally different.
Okay. Yeah, I
Yeah.
was just curious if there was anything correlating that, but perfect. Thank
No, it's based on the uterine lining, and hormonally driven. Yeah.
Okay, thank you.
Mhm.
This may be a similar question, but it was just ways of deciphering an athlete's normalcy versus if they're on contraceptive and maybe they're under fueling, and ways of detecting they lose their period due to contraceptives. Are they under fueling or is it a combination of both?
Mhm. I mean, that's honestly why I like body composition tracking. The number one way you'll see that is with lean mass changes. And having like historical data, for instance, it's normal for many athletes to lose muscle during season. For instance, like, I mean, it can be impacted by a lot of things, but how large of a change and what are those individual changes? Lean mass is the number one indicator of underfueling, and you'll see it much quicker than things like bone and even menstrual cycle loss.
Also, is there a time when an athlete may be advised to switch which contraceptive they're using or to rid it completely?
100%. And it's actually pretty interesting. Like I would say, I mean, I've been here for a while, but 10 years ago, you could never find a female not on hormonal contraception. And now, 10 years later, we actually struggle to find females on hormonal contraception. And I think it's due to this increased conversation. So yes, there's so many different types of contraception that should be dictated by the rationale or side effects the female is experiencing. Right now I've seen a lot of females just stop taking it altogether. Yeah, so I mean, that's definitely a conversation to have with a provider.
I was telling them that the study we did over COVID was like less, I think we were like 45% or 48% or something for those who took OCs.
Mhm.
All right, we just have time for one or two questions.
I was gonna ask, so I assume you've probably read or at least heard of You Can Droop's review that came out a couple months ago on Reds. And he brought up the idea of Reds and LEA being just overestimated because of miscalculations in energy expenditure and energy intake. What are your thoughts on that review? And like, do you think that it is overestimated? What do you think? Do you think Reds or like overtraining syndrome would be more common in athletes?
That's a great question, $1 million question. I think it's such like a political space, meaning like in reality, it's really hard to capture not only energy intake, but also energy expenditure. So when we look at absolutes, I think some of the cutoffs and some of the standards are a bit too black and white, like as far as how prevalent it is. But when you really look, and I don't know how many of you guys are currently working with female athletes, they're all under fueling. It's just hard to get enough fuel, and that's where we should be spending our time. And the question is, what I always find interesting that I wish we had more data is oftentimes you don't see symptoms of low energy availability and Reds until sometimes several years after this underconsumption. And so I think it's more of a conversation of like, how sensitive is that? And like, what are even things that we can do to ensure more fueling to prevent some of those side effects? So I think there's still so much we don't know. Prevalence wise, like, I don't know if I've actually seen prevalence numbers. And when you look at the sports, you can probably say like it's the same conversation we need to have. And it doesn't really matter the prevalence. It goes to the experience with working the athletes. We don't need to make it political. It should be a conversation. How do we more optimize fuel? And then what are those early symptoms that we can start to tackle before we actually get to Reds?
Hi, yeah, so that was kind of my question. I was gonna ask, do you think the research right now shows that more sports teams should be actively individualizing nutrition just based on where they report their cycles at, or should they just be looking at those big picture things like just energy availability, like for all athletes? And yeah, I don't know.
That's a good question. I would say first and foremost, like most, I mean, I can even think about here at UNC, like every female athlete should have some sort of menstrual cycle support, even if it's teaching them how to track their own cycle. They're the first line of defense. Does that mean that they then need to overhaul their nutrition around their cycle? No, but then they start to see like, oh, it's championship season. I'm going into finals and I lost my menstrual cycle. Is it because I'm underfueling or is it because I'm stressed and underslept? And so, but very few females are tracking their menstrual cycle, or like even here we have teams that intentionally kind of pair their contraceptive path at the same time, like they'll skip a week so that during championship season they don't actually bleed. There's more conversation around like, okay, how can the actual menstrual cycle be helpful? How it's an indicator of health. And it also should help us say, okay, like there's times with different hormones that you might need to have an extra snack or prioritize what you eat. So to answer your question, it does need to be individualized, but that's not just on the providers. It's again, creating an environment of teaching these athletes about themselves and then having that conversation and those resources so that it's there if they need it.
Thank you.
All right. Thank you for your time today, Abby. I want to do one last 2-second question, which is if we want to track menstrual cycle, I know that you and your lab are using some like various like apps and things for this, and also like daily things you can use with like urine testing and stuff. What's your app we should have downloaded so we could look at some tracking?
Honestly, it's more of like whatever someone will use. Consistency matters. And I would say, like, I see some of the guys thinking like, this doesn't apply to me. But if you have a mom or a significant other, or you eventually have a daughter, like knowing where they're at in the menstrual cycle is immensely helpful. And so we use in the lab Fertility Friend. And then I don't know if Katie talked about, she's doing some work that we've also used with daily urine tracking. Anito and Uva is really fascinating to see where those daily hormones are. Because, and let me show you, I think I have this slide in here. Maybe I didn't put it in my slides. The idea that every female cycle is very cyclical is somewhat of a disillusion, is that there's so many differences in cycles. So by tracking and by getting some daily urine hormones, we have a running joke in our lab of like, I'll have a student come in here and they'll like just be a little bit like need an extra hug or maybe a little extra emotional, and they know it's because they're in their luteal phase, and it's not a bad thing, but they're like, oh, this is why I'm feeling this way. And so it really gives some empowerment to women to know like, oh, I actually feel great, I just am about to ovulate. There are physiological effects of knowing that that can be helpful.
Sure. And just because out of curiosity with the urine test, I assume you need like a kit or something. How does that work with an app on a phone?
Yeah, okay, so, well, some of them now, like Clear Blue, as minimal as ovulation testing is really helpful, even if you're just not trying to get pregnant, but also tells you when you ovulate, which is optimal fertility and also increased libido. And now they have some perimenopause ones, but for the at-home urine test, it's essentially, I wish I had one in my office. It's like essentially you just slide it on your phone and it uses a QR code to read the hormones. It's very fascinating and it seems to be pretty accurate. And so it was originally used for fertility, and now it's moved into perimenopause to see some of those fluctuations, or what we see in perimenopause. They're either really dramatic or there's none at all, which can really impact a lot of that cardiometabolic health, the brain fog, anxiety, etc. So yes, you do have to usually buy something, but it's honestly not that expensive. I think a tracker, maybe $70 that you can use and reuse, and then the sticks, I can't remember, like $15, $20, something like that.
Okay, awesome. Thank you so much. Let's give her a big round of applause.
Thank you. Thanks for having me. Thanks for the questions.
We'll be in touch. Thanks so much.
All right, have a great day, everyone.
Bye.
Bye-bye.